Hello, guys. It was really good time to discuss with you electrolytes in this mastery. And we're going to have some practices right now, and just you need to gear up. The first question is about Abdullah, who's a 30-year-old man, is known case of schizophrenia on risperidone, who was admitted with sodium of 120 and has severe headache. Urine sodium was 200 millimole per liter, and urine potassium was 56, and urine osmolality is 300 milliosmol per liter. What would be your action for this patient? This mostly drug-induced IDH, only fluid restriction, or you will give 3% saline for this patient as he has symptoms and he's young. You'll give like normal saline 1 liter over 6 hours, or fluid restriction and normal saline 1 liter over 24 hours. The answer is a 3 saline. Why 3 saline? There are two things like dictating your answer: the level of sodium, and he's being young. There is no space in his brain to accommodate any fluid that might be detrimental. So just keep this in your mind, that young patient and severe hyponatremia or like borderline severe hyponatremia, plus a couple of like symptoms, you need to act on that, not just fluid restriction. When we calculate the urine tonicity for this patient, it gives you sodium and potassium. When you add them in the urine, that will give you the urine tonicity. What we can withdraw from the urine tonicity? If patient is given a liter of isotonic saline, which contain 154 millimole or milliequivalent of sodium, what does that lead to? The plasma sodium will initially rise with that infusion, but all 154 millimole of infused sodium will be excreted. In fact, since sodium handling is intact in its IDH, there is no problem in sodium handling. The problem is just water retention because of inappropriate ADH secretion. But the question is, the tonicity is 256. It means every 256 millimole of like cellulose would need a liter of urine to be excreted. But this patient was given 154 millimole. It means that it would need just 600 ml of water, and the remaining 400 ml of this infused saline, the liquid or the water part, will stay in the patient. That would be the reason for dropping his sodium rather than increasing his sodium. Let's just focus more. Urine tonicity in this patient, as we mentioned, is 256. Like every 256 millimole needs a liter of urine to be excreted in. When you give 154 millimole in liter of saline, it needs almost 600. And this exactly what does it tell? 256 solutes need a liter, but 154, how much would it need? You would do the double cross, and that would give you like 154 solutes, or sodium would need only 600 and will retain 400 water. That's why when you give saline for SIDH, it will drop the sodium rather than increasing the sodium, and it's called desalination process, in fact. What about if you give hypertonic saline in SIDH? Let's just do the same practice. So the 3% has 513 millimole per liter, and a liter of 3%, when you give a liter for the patient, this means that it would need, we'll do the same thing. Like if 256 is the tonicity, that it means that 256 solutes will need a liter of a fluid or a liter of urine to be excreted in. What about 530? How much would it be? You do the double cross again, and the double product, the cross product. So the cross product would tell you that the amount of urine that a 513 sodium would need is around 2 liters. What does this mean? means that if this patient weight is 70 kg, the total body fluid is, as you know, is 60% of his weight, that is 42, and the total sodium will equal 120 times his all volume, that it would give you the sodium pole, which is 5,040. But the new volume is not 42 because he excreted or he urinated 2 liters because of the solutes in there in the 3%. So then you divide the sodium pole on the new volume, and that would raise the sodium because the patient lost fluid, and mainly that what he lost, in fact, is water, and here is the new sodium. And this is the difference between giving saline to IDH compared to the 3%. Let's go to the second practice. Salha is a 55-year-old lady who presented with symptomatic hyponatremia after starting phase I for hypertension. Her initial sodium was 120 from the baseline, which is 138. She was given 3% saline, 20 ml per hour, aiming for a total of 300 ml of the 3%. Repeated sodium after 6 hours was surprisingly high, 131 from 120, remember, in 6 hours. And urine sodium was low, was 18. If the patient body weight is 60 kg, what do you think the reason for the rapid correction of her sodium? The question is giving you different scenarios, telling you that the rate of fluid was, 40 ml per hour in 6 hours. And then it tells you that every scenario tells you that the patient urinates this amount, like 300 or 1,000 or 1,500 or 1,500, and was given D5 water, or she drank actually water, or that she urinates 2,000. So which scenario would fit? This is a good practice, and I think when you focus and understand this, you'll understand a lot. Let's go through this math. This lady has 60 kg weight, so 50% of her body weight is a fluid, that is 30 liters. So 1 liter of 3% has 512 or 13, or let's say that 512 millimole of sodium is there in 3%. We know that the rate was like 40 ml per hour for 6 hours. It means that she got 240 ml. So what does this mean? How much sodium in 240 ml? Then you calculate 240 times 512 divided by 1,000 will give you 122.8, like 123. So she got sodium of 123. So 123, when you divide it by the body weight, gives you 4.1. It means that this sodium amount, which is 123 millimole, if you give it to this patient who is having 30 liters of a fluid, this would raise the sodium by 4 per liter. It means that 120, it would become like 124. But this patient was like more than 124. So this is not the answer. And we cancel the urine output that she put 300 ml because 300 ml was out, but the patient was infused. Sorry, this is infused 240. So almost the same. So the N, which is 240, was canceled by 300 ml. So that was not calculated, but we would see this calculation in the second choice. So if urine output was 1 liter, this will make the new volume as follows. She has 30 liters. She was given 240 ml, but she lost 1 in the urine, 1 liter. So this means that the new volume is around 29 point something. The total body sodium is 120 times the total body fluid, which is 30. This is the total body sodium, 3,600. The new sodium is 3,600 plus 123. And it tells you in the question that there was like 18 millimole per liter of sodium was lost in the urine. And she lost 1 liter, so she lost 18. So the new sodium would be the calculation of all in and out. So 3,600, the total sodium pool, plus 123, that is 3% infused, minus 18, that is the sodium lost in the urine. That would give you this amount, 3,705. The new sodium concentration would be the sodium, the total sodium, divided by the new volume, it would give you 126. And this is not the answer. We did not reach to the sodium that the question gave us to. If urine output was 1.5 liter, again, we'll do the same thing. We'll do the calculation. The new volume would be this. And the total body sodium by the same thing. Then the new sodium would be 3,600 plus 123 minus 18 minus 9 because she lost 1.5 liter of urine. In each liter, there is 18. So in each half liter, there is 9. So she lost 18 and then she lost 9. And this is the new sodium. This is 3,696. And the new concentration would be the new sodium divided by the new volume gives you 128.6. And this is not the answer again. D is almost same as C, but the patient drank like 0.5 liter. You will add that to the fluid. In fact, drinking water will drop the sodium rather than increasing it. So that's why it is less than that in the C. And E, the patient urinated 2 liters, in fact. So the new volume would be 30 plus the 240 that was given by the 3%, and minus 2 liter in the urine, that is the new volume. And the new sodium is 3,696 divided by the new volume. It gave us the answer 130.8. That's a fascinating question. The practice 3 is simpler. Mariam is a 70-year-old lady presented with decreased oral intake and possible urosepsis. She has uncontrolled DM. Her sodium was 166 millimole per liter. Glucose was 400. Weight is 60 kg. All are true except. My sodium target in first 24 hours is 156. You know, like you're dropping the sodium by kind of 8, and as if you're dealing with her as chronic hypernatremia, should be careful. Or remeasure sodium level after correcting glucose within 2 hours to guide the sodium correction rate. Or using corrected sodium to level of glucose is accurate and highly reliable. Or replacement fluid can be divided between IV route and oral. Or A and C. Remember, we need the wrong answer. My sodium target is 20, and 24 was 156, ignoring the glucose, ignoring the, is this the right way? And the second thing, is it really reliable that you calculate the sodium, you correct the sodium based on the glucose? We're not sure about how much, that water shift because of a glucose would change the sodium. So the answer is, in fact, is A and C. You need to remeasure the sodium level after just lowering down the glucose, and that would be, a better way of treating such patient. This is a good question, and I think the nurses should be very aware about this, but physicians as well, they should be aware of this. You order to start IV fluid as saline infusion at a rate of 60 ml per hour for a volume depleted old lady. The second morning, you found her in pulmonary edema, and your consultant stopped the IV infusion and said, calculate the rate from the drops at the IV set you are seeing. How can you calculate? Each 20 drops equal 1 ml, so 60 drops per minute is 180 ml per hour. For each 40 drops, for each 10, for each 50. In fact, it depends on the IV set, the drop factor, you have to see it. And then you should calculate the number of drops per minute, and you multiply by 60 because you're doing it per hour, and you divide it by the IV set. That it might be 15 to 20 in the macro drops, or 45 to 16 micro drops, and then that would tell you, in fact, what will be the answer. Practice 5. Abdullah is a 65-year-old man who is known to have end-stage renal disease, presented to dialysis unit with acute confusional state and bilateral abnormal movement. It was choreiform, mainly in the upper limbs. Upon careful examination, you found a vertical nystagmus. What is the most likely diagnosis? Severe hypomagnesemia, severe hypocalcemia, bilateral basal ganglion infarction, uremic extrapyramidal signs. So what do you think? So when you see vertical nystagmus, always remember severe hypomagnesemia. Yasser is a 37-year-old man who's known to have morbid obesity with BMI of 42. He heard about the effect of obesity on kidney health, so decided to start dieting using low-carb diets, like keto strategy. 2 weeks later, he presented to ER complaining of muscle ache and generalized weakness. His serum potassium was really low. It was 2.3 millimole per liter. What is the most likely cause of severe hypokalemia? Is it decreased oral potassium intake, increased GI potassium loss, increased urinary potassium loss, or increased insulin secretion leading to transcellular shift? Of course, this patient has no much insulin because he's avoiding carbs. So the D is clearly wrong. Is it decreased oral potassium intake? Per se, it's not enough to cause low potassium unless there is loss in GI or urinary. And mainly we know that the urinary loss is the main reason, in fact, for hypokalemia, especially in this patient who is having ketoacids. We name it as non-absorbable anions. These non-absorbable anions, when it goes to the kidney gets rid of them, and most of the time it couples them with potassium. That's why they're liable to get severe hypokalemia. Faris is a 16-year-old boy presented with lower limbs weakness for a few hours associated with difficulty for breathing. His father said that he was playing soccer happily with his friends with no single problem. His blood work were fine except for potassium of 2.2 millimole per liter and a very suppressed TSH. You suspected pyrotoxic periodic paralysis and gave IV potassium and IV PTU. His repeated potassium every 2 hours were 2.8, 3.2 millimole per liter. The nurse called you after 5 hours because of abnormal ECG finding that you confirmed as atrial arrhythmia. What do you think the repeated potassium would be? Well, would it be 2.2, 6, 3.5, or below 2? Remember, this patient is having pyrotoxic periodic paralysis, and these patients are liable to get what's called rebound. So 6 is not, surprising if you see potassium of this patient at this level, especially if there is severe thyrotoxicosis. So thyrotoxicosis, the more severe thyrotoxicosis, the more liable to get rebound hyperkalemia. So that's why you should be very careful in those patients. Muhammad is 18-year-old man known to have pseudo-hypoaldosteronism type 1. This is my patient, in fact, presented with symptomatic hyponatremia and metabolic acidosis, accompanied by mild renal impairment. He needed volume expander in form of isotonic sodium bicarbonate, and his uric acid was elevated to 800 millimole per liter, for which allopurinol was initiated. 2 days later, he was found to have severe hyperkalemia that was intractable there. It was not responding to any treatment. In fact, we initiated him on dialysis for a very refractory hyperkalemia. Though that the eGFR was 50 ml per minute. So what would you do for this patient? Immediate calcium gluconate, dextrose, insulin, CBC, and LDH level. immediate hemodialysis, serial cardiac enzymes, and CBC. Stop allopurinol and give rasburicase. Give fludrocortisone loading of 1 milligram followed by 2 micro-D. Well, every one of them could have like correct part, but let's just focus on a patient who has refractory hyperkalemia after starting allopurinol. If you go and read about allopurinol, it could cause hemolysis. That's why hemolysis was the reason for increasing his potassium, and his LDH was in thousands. So that's why you should give this patient, his level of potassium is sky high, calcium gluconate, you shift the potassium, dextrose, insulin, you do CBC to find the reason if there is hemolysis or not, and LDH. The thing of dialysis, as you wouldn't jump for dialysis before giving those measures. Ibrahim is a 70-year-old gentleman who is recently diagnosed to have diffuse large B-cell lymphoma on first cycle of R-CHOP 2021 therapy. 4 days later, he was brought to ER with muscle ache and decreased urine output. Tumor lysis syndrome was diagnosed with the following blood works: potassium 6.2, phosphate 3.3, calcium is 1.6, uric acid like typical tumor lysis, and the creatinine was 400 from baseline. Normal baseline. ECG, there was no acute changes. So what would you do? You alkalinize the urine with aggressive hydration followed by calcium infusion as 2 grams calcium gluconate over 30 minutes, or you do aggressive saline infusion, rasburicase along with 10 units IV regular insulin, aggressive IV saline, allopurinol, IV insulin, and calcium gluconate, or you go immediately to do hemodialysis. Well, tumor lysis, the first thing, before you give like a bicarbonate and alkalinize the urine, and you might increase the chance of phosphate stone formation, because by alkalinization the urine, if you exceed 8, a pH of 8 in the urine, that would precipitate phosphate. Yes, it would dissolve the uric acid, but it's risky. So before alkalinizing the urine, you just give aggressive infusion and rasburicase. Of course, if the uric acid is as this level, it will dissolve uric acid, and even this acute kidney injury could improve. If not, then the dialysis would be the other chance. You look to this flower, it's a beautiful one, but it's toxic. You should be careful. This is called foxglove. Let's see. Faisal is a 28-year-old man who is known to have end-stage renal disease on peritoneal dialysis, recently shifted from hemodialysis due to access failure. While he was traveling to Europe, he missed his peritoneal dialysis sessions for 3 nights and presented to ER with volume overload symptoms, abdominal pain, vomiting, and diarrhea. His potassium came to be 7. He admitted eating a few petals of flower called foxglove for fun. You decided to start him on high-dose peritoneal dialysis immediately and give calcium gluconate up front, because potassium is 7. What precautions you should take care of in regard of calcium administration in this case? Give calcium chloride, but not a gluconate. Lower down potassium level quickly, as hyperkalemia potentiate foxglove toxicity. Infuse calcium over 10 minutes instead of 3 minutes as usual concentration. Dilute calcium in 100 ml B5 water to be given over 30 minutes. Foxglove has, in fact, digoxin. And digoxin, when you give calcium, digoxin, it works by increasing intracellular calcium. So that would increase the contractility. So if you give calcium to a patient who is on digoxin, that would cause more toxicity because of the calcium itself. So So giving calcium gluconate to a patient who's in digoxin would be, detrimental. That's why you need to, dilute the calcium, and instead of 50, you give it in 100 ml, and instead of giving it over like 10 or 20 minutes, you give it like in 30 to 50 minutes to be in the safe side. Then ask the question: 60-year-old gentleman presented with decreased level of consciousness because of this level of sodium, like 115 millimole per liter. His weight is 70 kg. So remember that whenever it is not known, I mean, the sodium is like 115 with no previous reading, we assume that this is a chronic. So how would we deal with this patient who's having symptoms of hyponatremia? Of course, we need to raise his sodium, and raising sodium, it does not need like 24 hours. You need to raise his sodium and save this patient within like 6 hours. Raising sodium by 4 to 6 millimole in 6 hours, always safe, especially in a symptomatic patient who needs, to improve his symptoms, or even if there is severe hyponatremia, especially in young patient, even if there is no symptoms, when you raise it by 4 to 6 within 6 hours, that will prevent brain edema. That will make you unique, that you work upfront before catastrophes could happen. So this patient has sodium 115, and I want to increase it to 120. It means I want to increase it 5 millimole in each liter. And the total liter he's having is like 42. It means that I want in every liter 5. So 5 times 42, I need 210 millimole as total sodium. How would I give this? I would give this, of course, either 3% or saline, but this amount, 210 is good amount. So, and I need to increase it in short period. That's why I choose 3%. So a liter of 3% has 512 sodium, but I don't want 512. I need only 210. I need only 210 as has been calculated. How many ml of 3% can give you 210? I'll do the double product or the cross product, and that would give me 410. So 410 ml, how would I give it? I could give half of it, like 150 or 200 over like 20 minutes or 30 minutes, and then I will recheck the sodium, and of course I will monitor the urine output. Of course I will monitor the urine output, and I might give desmopressin as well, just to make sure that the patient would not overcorrect. And if you want to give not 3%, if you want to give like half, no one will give half saline, of course, see the amount that you would need. But saline, for example, it has 154. And when you do the same way, like the double or the cross product, that would tell you need 1,363 ml of saline. Of course, no one will give this patient saline, and we prefer to give him like a 3%. Again, about the desmopressin. You can give desmopressin like every 8 hours to make sure that the patient will not urinate free salt urine, because that would cause rapid correction of sodium, even with a small amount of 3%, because it will shut off ADH, and you will see the rapid correction that you would not like to see. And this is the end of it, and good luck.